Another session of RISA DNB online academic activities today. We are continuing ahead with DNB theory examination question discussion with Professor. Today's session 10. I invite Dr. Shobika from Mount Hospital for presenting the answer for the first question. Over to Dr. Shobika, please.
Thank you, sir. Good evening, sir. My topic is on intraoperative anaphylaxis. The term anaphylaxis was coined by Charles Robert Richard and Paul Potier in the year 1902. Anaphylaxis is defined as a severe, potentially life-threatening systemic hypersensitive reaction to a substance to which the individual is already sensitized. Pathophysiology. Anaphylaxis can be caused by immunological mechanisms and non-immunological mechanism. It could also be idiopathic. Immunological mechanism. IgA-mediated anaphylaxis is a type of hypersensitive reaction caused by cross-linking of IgA antibody with IgE receptors, resulting in degranulation of mast cells and basophils. Initial sensitization to an allergen has no clinical manifestation. When re-exposure to the allergen, the receptor-bound IgE aggregate and stimulate the sensitized mast cell and basophil degranulation, resulting in the release of inflammatory mediators such as histamine, prostaglandins, proteoglycans, cytokines, leading to clinical manifestation of anaphylaxis. In non-IgE mediated anaphylaxis, the hypersensitive reaction is stimulated through immunoglobulin G and immune complex complement mediated pathways. Next is non-immunological mechanisms. Non-immunological mechanisms of anaphylaxis does not involve immunoglobulin and is due to direct stimulation of mast cells by the causative agents like drugs. Similarly, there will be degranulation of mast cells and release of mediators such as histamines. It is usually transient and may present with just cutaneous signs. And then idiopathic anaphylaxis. It is diagnosed only when no specific allergen can be identified from history or skin test. There is of elevation in serum specific IgE levels in idiopathic anaphylaxis. Common risk factors of anaphylaxis: past history of atrophy, drug or food allergy, multiple operations, systemic mastocytosis, hereditary angioedema, etc. Perioperative anaphylaxis triggers includes the following: neuromuscular blocking agents. Anaphylaxis due to neuromuscular blocking agents is because of IgE sensitization towards the quaternary ammonium groups in NMDAs. The most commonly associated with anaphylaxis are rocuronium and succinylmethonium. Direct mast cell degranulation is mediated by atracurium, cis-atracurium, mevacurium, doxacurium, and D-tubercurium. And then local anesthetics. Anaphylaxis reaction to amyl local anesthetic is rare. Metabisulfite in local anesthetic can cause allergic reactions. Vasovagal response, tachycardia, lightheadedness, metallic taste, and perioral numbness is seen with local anesthetic drugs. Next is opioids. Anaphylactic reactions are pretty rare. Morphine and mephedrine is most commonly implicated. Fentanyl is deemed to be the safest opioids. With induction agents, incident of anaphylaxis is not common. Incidents of anaphylactic reaction with thiopentone have been recorded. With propofol, reactions may be due to egg-lecithin, but it is not contraindicated in patients with egg allergy. Etomidate is immunologically safe next to ketamine. With benzodiazepine, the reaction is very rare, most likely occurs with diazepam. No reports of anaphylaxis with volatile anesthetics have been recorded. However, immune-mediated hepatic injury is seen with halothane. With heparin, derived from bovine or porcella, reactions occur in the form of heparin-induced thrombocytopenia. It is seen less common with low molecular weight heparin. With antibiotics, which are commonly associated with anaphylaxis, are penicillin, cephalosporin, and carbapenems. Other agents that might trigger anaphylaxis include chlorhexidine, povidone iodine, latex, isosulfane blue dye, iodinated contrast material, and then colloid. Anaphylaxis is a clinical diagnosis. Clinical manifestation of anaphylaxis in awake and under anesthesia patients includes the following. In awake patients, the cutaneous signs includes flushing, pruritus, urticaria, angioedema. Cardiovascular signs includes tachycardia, dysrhythmias, serious collapse, cardiac arrest. In CNS, the patient might have confusion, decreased level of consciousness. In RS, the patient might have cyanosis, wheezing, rhinitis. In renal, the patient might have decreased urine output. Signs commonly noticed under anesthesia patient are rashes, tachycardia, hypotension, dysrhythmias, increased airway pressure, decreased end-tidal carbon dioxide, desaturation, cyanosis, and decreased urine output due to acute tubular necrosis, acute kidney injury. Disseminated intravascular coagulation can also be seen with anaphylaxis. Anaphylaxis should be suspected if there is unexplained hypotension, refractory to vasopressors, or unexplained difficulty in ventilation and bronchospasm. Severity of anaphylaxis can be graded clinically as adapted from the Ring and Mesrimer 4-step grading scale. So grade 1, there will be generalized mucocutaneous signs of erythema, urticaria, and angioedema. In grade 2, there will be multi-organ manifestations like mucocutaneous signs mentioned above, bronchospasm, and hypotension. In grade 3, patient might have severe life-threatening multi-organ manifestations like arrhythmia, cardiovascular collapse, and bronchospasm. In grade 4, patient will have cardiopulmonary arrest. Diagnosing anaphylaxis can be difficult because these signs may also arise from other anesthetic, surgical, or patient-related factor in peri-op settings. Coming to investigations, lab tests are not useful in diagnosing anaphylaxis at time presentation because they take time to process and are prone to false negatives and positives. Still, the investigations includes elevated level of carboxypeptidase, complement C3 and C4 levels taken at 30 minutes, 1 hour, and 4 hours post episode, and then tryptase estimation. Blood sample is taken after 30 minutes and also repeat sample at 6 hours and 24 hours. We also have skin prick test and intradermal skin test. It is done 4 to 6 weeks after anaphylactic episode due to mast cell depletion. And then patch test can also be considered. Patch test containing allergen applied to skin. And then we have radioallergosorbent test. It measures the presence of specific IgA antibodies in serum. Other tests includes ABG, LFT, RFT should be considered to detect hypoperfusion injuries in other organs. Coming to the management, immediate management of anaphylaxis, to stop the administration of all agents likely to have caused the anaphylaxis, either to terminate or rapidly complete the surgery, call for help, maintain airway if necessary, secure it with tracheal tube, give 100% oxygen, and ensure adequate ventilation. And then for the optimization of cardiovascular status by IV fluids and position of the patient, IV fluids 20 ml per kg bolus titrated to effect and position to lay the patient flat with legs elevated to increase the venous return. And then to administer epinephrine in titrated doses with close hemodynamic monitoring. Intravenously 50 to 100 mics of adrenaline over 1 minute and repeated as required. IM adrenaline is 0.5 to 1 mg and repeated every 10 minutes if required. For serious collapse, 0.5 to 1 mg of adrenaline is administered intravenously in divided doses. Corticosteroids may help to prevent the recurrence of anaphylaxis after the initial management. Hydrocort of 2 to 4 mg per kg, 100 to 2, usually 100 to 2 mg slow IV is given. Consider peroral non-sedating antihistamines when awake. Alternatively, chlorpheniramine 10 mg slow IV can be given. And then invasive blood pressure monitoring allows better titration of adrenaline, and central venous catheter facilitates administration of vasopressors and ionotropes. Post-crisis management, adrenaline infusion of 0.05 to 0.1 mics per kg per minute can be maintained if required. Resistant hypotension can be managed with vasopressors such as noradrenaline, vasopressin. Patient who is on beta blockers, glucagon can be given to reverse the beta blocking effects to improve the hypotension. Resistant bronchospasm can be treated with bronchodilators such as salbutamol. Then sugammadex, a reversal agent for neuromuscular blocking agents, can be used to reverse the anaphylaxis triggered by rocuronium. And then we have to check for the presence of airway edema by letting down the ETT cuff and confirming a leak prior to the extubation. Even with adequate response to treatment, patients should be meticulously monitored for at least 6 to 8 hours if they had respiratory compromise and 12 to 24 hours if they had cardiovascular compromise. If the patient condition does not improve with first-line intervention, differential diagnosis can be considered which is pulmonary embolism, tension pneumothorax, exacerbation of asthma, sepsis, cardiogenic shock, myocardial ischemia, mastocytosis, clonal mast disorders, etc. Follow-up. After a suspected drug reaction, anesthetist is to counsel the patient along with the immunologist. It is mandatory to observe the patient in ICU setting for 8 hours. Immediately after resuscitation, 10 ml of venous blood should be taken in a plain glass tube, serum separated and stored at -20 degrees Celsius for estimation of tryptase concentration. When more than one drug has been administered, skin prick tests are useful. That's it.
Okay. You got all this information